of a cheesy photo, but just to accentuate the point that we're talking about something that happens to all women, that's going to affect every woman that lives into middle age, and therefore is going to affect all humans, because everybody is going to know and care about somebody that goes through this transition at some point in their lives. So first thing I wanted to have a quick chat about is testosterone, and why might testosterone be something to consider adding to your HRT. Now, at the moment, our local policy is that for most people who are going to be given testosterone, that comes via waiting for an appointment within the hospital setting to see someone like myself with a special interest in menopause. And that's because testosterone is currently unlicensed for women in this country because of a lack of really good quality evidence of the benefits of testosterone and a lack of any long-term safety data. Having said that, we have got some evidence to say that for many women, it can improve libido, can improve sexual function, sexual desire. And in terms of our short-term data, there doesn't seem to be any real safety concern from adding testosterone. Many women who take testosterone as part of HRT do report that they feel there are some other benefits from taking it. So that might be a reduction in those brain fog symptoms, increased stamina, less fatigue. That is not borne out in the evidence-based research we've got so far. But there isn't a huge amount of research going on. This isn't very lucrative for pharmaceutical companies, so we haven't got a huge amount of data to draw from. There shouldn't be side effects from taking testosterone if we are keeping testosterone levels within female physiological range. But we don't want testosterone levels to go more into a male range, because then that can cause a number of side effects. So side effects might be head hair loss or facial or body hair growth, skin changes like acne, weight gain, can also result in more extreme circumstances in a deepening of voice or in an enlargement in clitoris, but that's over a longer term of being above female hormone range. So because of those risks of side effects, we do need to look at blood levels, and we would take baseline testosterone levels before we started the prescription to make sure that those baseline levels weren't at the higher end of normal or weren't raised for any reason. And then we would check blood levels again a couple of months after starting testosterone therapy to make sure they're in female range. And the guidance is after that, we should probably be checking testosterone levels approximately yearly to make sure we're staying in that safe range. I would say testosterone is certainly not necessary for everybody on HRT. It's only really required in the minority of people, because you've heard lots in the previous talks about how it's estrogen deficiency that is prompting all of those menopause symptoms, and it's the ovaries sort of switching off their function of producing estrogen that's resulting in the menopause. So replacing estrogen is the most important thing, and for most people that's all that they need. But there is a subgroup of people where testosterone can be like the sprinkling on top of the cake. It can be something that we can add in. It's something in our box of tools that may be helpful as part of HRT. I would say, and we've already covered this to some extent, that sexual desire is a really multifactorial thing. It's influenced by a lot of things apart from hormone levels, by daily stresses, by fatigue, by relationship issues. So there isn't a magic pill or a magic gel that you can rub in that is going to totally change that or correct it. But testosterone gel can be a part of that. And I tend to recommend my patients to look into Dr. Karen Gurney, who is a clinical psychologist who specializes in psychosexual health. And she's got a really good TED talk talking about sexual desire, particularly in the context of long-term relationships. And she's got a book as well. So that can be a really useful resource. Next thing I was going to mention, another reason why you might come and see a hospital specialist is if the HRT really isn't working. There's not a magical solution to this either, but there are a number of things which your clinical pharmacist or your GP can initiate, and then which we can experiment with as well in secondary care to try and optimize HRT. So the first thing is, rarely do people start on HRT and that is totally fantastic for them. They're at the right dose, on the right preparation, and their symptoms are all corrected. Often it is quite a bit of trial and error. We need to increase estrogen within a safe range. Occasionally, there are circumstances where we would prescribe estrogen above licensed doses, but those are few. And then if we're increasing estrogen, as you've heard from Harriet, we need to think about increasing progesterone to protect the endometrium and reduce the risk of that. Different women will absorb different preparations of estrogen differently. So if symptoms are really poorly managed on gel or a patch or the spray, sometimes it is just swapping that preparation and then playing with the doses of different preparations to try and really get an individual HRT that's right for you. We don't routinely check blood tests for estrogen levels. It's a really poor way generally to guide treatment. And we've learned a bit about that from the science on the previous slides. So we know in perimenopause, estrogen levels can fluctuate really wildly. So this isn't a routine thing that we would do. But sometimes it is helpful to check those estrogen levels for people who really aren't absorbing transdermal estrogen very well, to say, look, your estrogen levels are really low and we need to think about doing something differently, or to show that actually estrogen levels look very much within a normal good range, and therefore maybe some of these symptoms are due to other physical or psychological issues that we need to be looking at, not just treating with HRT. If somebody is a really poor absorber of transdermal estrogen, which is our first line, kind of safest way of giving estrogen, then we can think about whether people go on a second line preparation, which can be taking your estrogen and your progesterone in tablet form. And many people will have low risk for blood clotting, low risk for things like stroke, and can be suitable for taking that HRT orally, so we can change the picture. It's about the whole picture of each individual. So it's looking at other life stresses, other physical conditions that are contributing to the picture, not just focusing on hormone replacement. And there are other really helpful things that you can add to HRT, like cognitive behavioral therapy, which can really help with vasomotor, hot flush symptoms and anxiety symptoms, and some complementary therapies. And then thinking about, is there another layer that we need to go to work as a whole multidisciplinary team? Sometimes that involves coming to a hospital menopause clinic. So we kind of touched on this already about when we would not want to give someone systemic HRT. And that's thankfully a relatively small proportion of women. So it's women who have acute liver disease and women who are suffering from or have previously had breast cancer or some of the higher risk benign breast disease. Acute liver disease is a pretty much absolute reason that we could not give HRT. People with a history of breast cancer, we would not recommend it. We know that HRT can increase recurrence risk, and it's very difficult to really statistically give people the exact risk, but we know that there is an increased risk there. But sometimes if people have explored lots of alternatives, that is not working for them. Sometimes it is about speaking to a menopause specialist, plus speaking to oncology team and breast team. And sometimes we can cautiously use HRT if it's really necessary to improve quality of life. Actually, the good news is that there are loads and loads of health conditions that we can safely use HRT alongside, sometimes with slight adaptations. So people get very nervous if they've got a gynecological history, fibroids, endometriosis. Those aren't reasons why you cannot have HRT, although it's really important to have a conversation with your doctor, your healthcare practitioner, about the fact that giving estrogen and HRT can cause growth of fibroids postmenopausally, can cause persistent endometriosis, which would kind of naturally stop with the decreasing estrogen levels of menopause. But those people with heart disease, diabetes, thyroid disease, we can safely use HRT. And people, VTE stands for venous thromboembolism. So people who've had blood clots in legs or lungs in the past, or who have a higher risk of developing blood clots, we can use that. We would very much recommend in that case using the estrogen transdermally. So those gels or patches which are absorbed through the skin. Already mentioned that migraines are not a contraindication, although migraines can be triggered by giving estrogen. So I would tend to recommend using patches. That gives quite a steady state of estrogen, and increasing the dose in really small increments. So it might take longer to get to a therapeutic level of estrogen because we need to be cautious about those dose changes, but we can use it. People with epilepsy who are on anti-epileptic medication, some of those medications can really affect the absorption of HRT. So that might be an occasion where we would need to give HRT at higher than licensed doses for it to be effective. One myth is that if you're having major surgery, you need to stop your HRT for 4 to 6 weeks before any big operation. And sometimes that advice still gets given. But generally speaking, that's not necessary, because modern HRT, where you're using estrogen through the skin, is not a significant increased risk for developing blood clots. So you can keep taking your HRT around the time of major surgery. And then just to mention, what's the alternatives? One thing I would say is that when we're talking about relative reasons why you can't take HRT, we're talking about systemically absorbed HRT that's circulating in your bloodstream. Using estrogen topically, so vaginal estrogen, to treat those symptoms of vaginal dryness, painful sex, urinary symptoms, can often be appropriate even for women who've got a history of breast cancer. Already covered from the other speakers a bit about all the lifestyle changes that can go alongside HRT or can help control menopause symptoms without the need for taking HRT. And there's lots of prescribable medication out there which can help with those vasomotor symptoms of hot flushes and night sweats that are not hormonal. None of those are as successful as HRT at resolving those symptoms, but for people who that's their predominant symptom and there's a reason why they might not want to or might not be able to take hormone therapy, there are lots of things which we can try. There's some evidence around acupuncture being really helpful in menopause symptoms, so obviously you can use that alongside conventional HRT. And there is a supplement which I mentioned to quite a lot of women I see in my clinic, which is called Femal. It's non-hormonal, so it doesn't contain any of those soya or phytoestrogens that are often in menopause supplements that you can buy. It's a pollen extract, which is a food supplement. And there's some limited research to say that that is a lot better than placebo at control of menopause symptoms. So sometimes that can be a helpful thing to have instead of or alongside your HRT.